wholeheartedly welcome M S RAVINDRA, who is a well-known ophthalmologist nationally and internationally in the field of cornea, and also an equally eminent national and international speaker, Dr. RISHI SWARUP from Hyderabad. Dr. M S RAVINDRA will be speaking first on ocular surface disease, and then Dr. RISHI SWARUP will be speaking on dry eye. I'm very grateful to you, sir, for the time that you have taken out to bless the postgraduates. This whole thing is becoming a knowledge bank for the postgraduates who are seeing now also, and then later also they go and see on the YouTube. They are getting hundreds and hundreds of hits on the YouTube links, which postgraduates are seeing in preparation of their exams. Thank you so much, Rishi, for taking out time, Dr. Rishi, for taking out time to bless the postgraduates with your presentation. I'd like to request Dr. Love Kochgave, who is a senior consultant, pediatric ophthalmology consultant at BBI Foundation, to please start the session as the moderator. Dr. Love Kochgave, please.
Thank you, Dr. Satyajit. And I would like to introduce the first speaker to all our PGs. And Dr. M S RAVINDRA is Chairman and Managing Director of Kartik Netralaya, Bangalore. And sir, both of us share two institutes. I am also a pass out from Bangalore Medical College.
Oh, okay. That's great.
He has done his MBBS from Bangalore Medical College and MD for from AIMS and fellowship from Shankar Netralaya. And he has multiple awards and orations to his credit. I will not name all of them because it will take 5 minutes for that. And I request sir to please enlighten the students on his topic, which is ocular surface disease.
No, right. Good evening. Thanks to Dr. Sinha and everybody who has worked to make this program a good success. I'm fortunate that he chose me to say something which is very dear to me. How do I enlarge it? Is that visible now?
Yeah, it's visible.
This one? Is that full screen or is it fine? On my screen, it's only a part screen.
Full screen only.
Full screen only. Okay, fine.
Love,
So,
can you see the presentation?
Yeah, I can see.
Not
fine.
doing.
Basically, the eye is exposed to the environment, and it is like any other part of our body, exposed part. It is liable for so many bombardments from the environment. And so you have an ocular surface disease, which can manifest in so many ways. It's just impossible to cover all of them. I'll try to cover a couple of them as time goes. I'm keen to listen to Rishi after me. So I would like to stop after 30 minutes whether I've finished or not. So this, I would like to touch upon the practical aspects, what we have seen that is the classical meibomian eye disease. And now the diagnosis wise, there are so many gadgets. You're all postgraduates will be familiar with all them. But what is most important is that Rishi will explain that Schirmer's test initially without anesthesia if it's necessary, which will combine the basic as well as reflex tears. But I would like to prefer a drop of proparacaine into the eye and put a Schirmer strip there and measure the tears as it fills up this over a period of time. The other is breakup time. So these are the two important for postgraduates. Rest of them is theory. They may ask you questions. You can keep that in mind. Diagnosis is very easy. You can see them outside. But what I would like to tell everybody is that suddenly when the patient comes, say hello, hello, then we go to the slit lamp. So torchlight examination, as you can see beautifully here, will give a lot of information. Torchlight examination, the right eye, left eye. There can be a mild ptosis because of upper disease. You will miss a lot of it if you do not see the patient face to face before you take him to the slit lamp. Slit lamp first, our everybody goes inside and see the pupil and what's behind that, but always start with examination with skin and lid margins, and if you don't do it, you will miss so many things. There can be a small chalazion there, which is causing problem. Even the patient may not be knowing about it. There's small lump. So examination is extremely important. How do you manage it? Can I push this strip to the side? Black strip, or it remains there. But how do we manage it? We are all familiar as to how to manage it. It's fixed. Okay. The after you diagnosis is done. Fine. Okay. After you diagnose myogomonitis, there are evident telltale evidences. The treatment is all is first the massage, hot fomentation, and massage are the main things. Massage of the upper lid is always done from top to bottom, and the lower lid is done from side to side. Gland expression, the glands have to be expressed out so that you have the meibomian secretion coming out. There are fancy gadgets available. If it's too much insipid, then you can go ahead and do that. And meibomian gland opening, theoretically, you can remember it. It's very fine needles, finer than 30 gauge, and which you can go inside and open the canaliculus, just like you do a lacrimal syringe, you can open it up. We have done a couple of them with a very fine cannulas, but I don't know how much improvement the patient had with them. Let me put you some case presentations. A 17-year-old healthy male came for, actually he was posted for a limbal stem cell transplantation in the right eye, came for a second opinion. His chronic, attacks of redness, pain, watering, blurring. This is what the importance of examination of the entire eye is concerned. So if you look at it, it looks like there is a panels, there are vessels coming from the limbus. If you don't look at the lid, it looks like something which is ready for a limbal stem cells transplantation. You have corneal cellularity in that area. There is some amount of clarity on that side, but more than half the cornea is affected. So look at the lids. Lids are absolutely bad. There is heavy myogomonitis there. You can see there, and that needs to be looked at. So this is actually basically a staphylococcal Blepherakeratoconjunctivitis, which you're all aware of the treatment. First, we did what are the standard treatments. We started on steroids also, and the ointment, Ocupol, dexamethasone eye ointment. Rubbing the eye is extremely important. This is to actually teach them. All of us know, but rubbing the eye is very important. And we also started tacrolimus because the disease is pretty advanced. And within 2 weeks' time, the entire thing has dried up. There is a scar, of course, and but you can see the vessels have regressed, panels has regressed. The stromal cellularity that is there, that's nearly it's as clear as on the other side. And symptomatically, the patient felt much better. And then you have see the lid margins, how clean it is. So to convert that kind of lid to this kind of lid in 2 weeks' time is a huge effort, and one has to put in a lot of efforts to do that. So that is the changes you see. So Blepherakeratoconjunctivitis is one of the commonest diseases which causes ocular surface disease. One has to be very, very aware of, and that's actually under the upper lid, which is more common in the lower lid, as you can see here. It's a very common disease. We start treating the eye without looking at the meibomian gland disease, that you'll have the patient has to come months and months together. And that's another case of MGD. Blepharitis, as you can see. And look at this person. Blepharitis, there is a cuffing of, you have to see it on slit lamp. Every lash is cuffed by something, as you can see here. So we keep asking them to rub, and they never get all right. So there's another case, chronic pricking and irritation, more in the morning and better in the evening. Look at this person. He had more symptoms in the morning, and as the day passes, it's better. The history taking again is of immense importance. You have to sit and talk to them about the computer vision and all that you'll have to look at. And the cornea looks absolutely clear, but when you stain it, corneal staining is absolutely essential for every case. You can see the patient has, on fluorescent staining, you have lag ophthalmos. The patient has lag ophthalmos, can easily miss. He has gone doctor to doctor hunting, then ultimately is landed up. Then treatment is very simple. ointment and patching the eye at night time. Within a week's time, it was much better. The other diseases that you'll have to keep it in mind, which is a very big topic, I will not like to touch it in half an hour's time. Stevens-Johnson syndrome does not have to be that severe. It can be very mild. One of the classical finding is the symblepharon. You have to avoid the upper lid and lower lid and watch for symblepharon. If the disease is chronic, you never miss it. Everybody will be taking a lot of medicines, but then you will not be able to identify root cause of it. But symblepharon is one of the root cause, and dry eye and surface disease. Fluorescent staining is absolutely essential for every case who comes with such symptom. Do that for every case from today onwards. And everything is not limbal deficiency. It's an inflammatory disease that you can see here, which has damaged this area. Inflammation has to be under control, otherwise your treatment may not work. Slides.
Showing 28 slides only, sir.
Yeah, and I have not put the next browser. I'll add. Am I already through my time? No. Yes. The next I would like to cover is the alkali burn or chemical burn, and again it's very common. What?
Sir, you have time till 7 o'clock, sir.
Fine. So is it visible now? What my slide? I've changed the PowerPoint.
Yes.
Fine.
Yes, sir.
Yeah, it's visible.
Ophthalmology is the blessed that we have no emergencies, but the true emergency, real true emergency is the surface burns. Time is very, very crucial. It's crucial than other emergencies because every second, every minute is important here. And you should be prepared all the time. Not that when a patient comes here, whether it's Deepavali time or a holy time or even otherwise, injuries, ophthalmologist has to be always, his OPD should be always prepared. I'll tell you a few slides later. The injury can be thermal, injury can be mechanical, you have to keep it in mind, and also chemical. History taking is of paramount importance as most of them are young males. It happens at workplace. Alkali is very common, and 2, 3 are minor. Young children will also come with trauma. Lime, holy covers, fire, gas cylinders, cooker explosions, gas geysers. So if you have a geyser at the bathroom, that can also blast and give rise to injuries. Steam, and it can be alkali or acidic. Alkali is more often, and it's because cleaning agents at home and building material have alkali involved in it. So these are the chemicals. I do not want to go through it. They're all in the textbooks. We should remember the ammonia causes the most serious injury, and the chunam is one thing which even a few days ago I saw a terrible injury because of chunam, and others you are very familiar. Batteries, industrial people with using glass itching, and the bleachers, they can have problems. So alkali, by various characteristic features, it reaches the ciliary body very, very quickly. And the moment the patient comes here, it may be actually too late. And you should tell the receptionist that as soon as a patient with any kind of injury comes, they should not bother about registration. They should not do anything. Directly hold his hand and bring to you wherever you are. And teach everybody how to wash, because the number one reason why we can have a better prognosis is thorough wash given soon after the patient's arrival. So the acid injuries are very, very limited. And there are several classifications. Let me not go in because they're all in the textbooks. So these are the classifications. Basically, what you should remember is the limbal burn, limbal avascularity. When you look at the eye, if half of the limbus is burnt out or in segments or exposed, you are in this category and prognosis can be good. But if the limbal capillary loss, it looks like white, it looks like a good eye, it's not a congested eye. Many times it's misleading. Cornea also can be clear because the entire epithelium is sloughed off. There is no epithelium. limbus looks good, and you will miss out the entire signs. So if the 50% of limbal capillaries are intact, that means you still have a very good chance of getting back the vision. And again, conjunctiva also, 50% of is involved and 50% is damaged. That's a cutoff point here. This is DEWSI's classification. What DEWSI has done is he has divided the 3 clock hours, 6 clock hours, 9 clock hours, and full limbus. They are very easy to remember. Here it comes 30, 30 to 50, 50 to 70 with the conjunctival involvement. There is an analog scale where he has combined that one and this one and gives a scale. So that's one. Prognostically, that's a better classification. And you should remember 3 phases in alkali burn. Acid burn, let us forget because it doesn't penetrate so deep like alkali. And the acute phase is within 1 week. This is important by pathophysiology also. It's important. And the early repair phase is 1 to 3 weeks. A lot of things happen after 3 weeks. So 20 days or 21 days, the management will change after 3 weeks. And the sequelae because of heavy burns. So as you can see here, epithelial defect, if it is full, we can't make out. Otherwise, fluorescence stain will clarify. Limbal ischemia. This is what I said is very misleading. It looks white. Anything with an injury with the white limbus, portion or full is bad. Then body reacts by pumping in all inflammatory stuff, anti-inflammatory stuff. Keratocytes try to build the cornea and the ground substance. And then you have, there's something blocking here, I can't see. Okay, fine. The mild, severe rise in IOP is something you have to worry about. The initial phase is because of the shrinking of collagen fibers, the globe size itself becomes slightly smaller. Even a minute shrinking of collagen fibers can increase the pressure, and also there is a trabecular mesh damage, which can give rise to decreased aqueous flow. This has to be managed. The patient has come newly, digitally feel the eye. If it is eye, then I'll immediately drain the anterior chamber. Put a after betadine and all, put a needle into the 30 gauge parallel to the iris, and fluid comes out. There are 2 benefits. Alkali also comes out, and also the pressure is reduced. And wash is the thing. And the healing process, you have epithelial ingrowth. Let me go little quickly here. I have 10 more minutes. And pathophysiology, I've already told you. Let us look at it. Epithelium growing is very important. Epithelial growing, regrowth, every day you have to monitor by staining of fluorescent, and you should be happy with the epithelium growth. Initially, the epithelium of the cornea itself will multiply and cover it. Later, limbal cells will take over. Limbal stem cells have to be healthy to take over, and in a week's time, it can completely epithelialize depending upon the extent of it. So as long as epithelium opening is there, the stroma never heals. For the stroma to rebuild, stroma to not to get damaged by the lysis, collagenolalysis, collagenolase, which is produced by keratocytes as well as PMNs. So keratocytes, the epithelium has to close. So your primary importance is to ensure that the epithelium comes back to normalcy as early as it's possible. So in grade 3 and grade 4, where there's a lot of limbal damage, more than 50% of the damage, a lot of conjunctiva is gone. The management is slightly different. Right from the beginning, you have to plan for covering. You can use AMT on the first day, second day, you can do the surgery. If the entire vasculature is gone, 100% of the limbus looks white, then immediately you can take him for a surgery, wherein you pull the tenons, go deep into it, just like a detachment surgery, you do a peritomy all around, go deep, pick up the tenons, which is there. Fortunately, it will be there because alkali wouldn't have perforated up to that. Bring it out and suture it on all the 4 directions. That is the way you bring the limbus into the vasculature into the limbus. So I think my time is past. Hello, am I audible?
Yes, sir.
Yeah,
You are.
yes, sir.
Are you still seeing my slides? They have just disappeared from there.
You can share it again.
Okay. No, I can't share from here. The sharing also is gone. It's not getting shared. No, it's gone away.
Maniji,
Sir, you need to see on the same main central bar where the share icon was there. On your main screen, sir, if you take the cursor, you will see the central bar.
No, I'm got it now. Sorry.
Are you getting, sir?
Yeah, it's opening.
Yeah, yes.
Yeah, basically what
it's coming, sir.
So
Yes, sir, we can see now.
Yeah, the instructions has to start from, I think I missed a couple of slides. The moment the patient telephones to you, you have to ask him not to rush to us, but then go to the tap and wash. Any fluid is all right. I think you're all aware of it. And the pH is, you have to have a litmus paper with you in the emergency kit, and always keep one bottle of RL, whatever in the OT it's available, keep it there, put the IV set and keep it ready. Or at least make a hole there with the needle. At the emergency side, you should not be hunting for things. Fluorescent stain, everything has to be available in a kit. We call it as a chemical kit and keep it in the outpatient department. If it is chunam, particles can be hidden. You'll have to do the lead diversion and remove it fastest. Parakinate drops is of extremely important. And the complete examination can be done later. First, you start washing when the patient arrives to your place. Wash for 1 hour, 2 hours, doesn't really matter. You can ask your assistant to do that. And you can, if it's severe burn, you can keep doing it. 2 to 3 liters of fluid can be taken. Generally, in my experience, about 500 ml of water or RL bottle, RL or normal saline is enough. But sometimes you may have to wash it till pH is neutralized. After pH is neutralized, continue washing for some more time and check the pH again after 10-15 minutes. These are very important things. The extent of limbal ischemia I've already corrected. I've told you 50% is the cutoff, good and bad, to classify them into good prognosis and poor prognosis. And yeah, I was telling about first week. First week there is an active distraction and body is trying to repair it. And second and third week, the body is really trying to repair it, and it can be provided. It can be improved upon by bandage contact lens, by amniotic membrane transplantations. It can be done 2 days, 1 day after the surgery, depending upon the damage. Now I'll rush through. This is the basis of the treatment. So many people don't start prednisolone because they think there is an epithelial opening, but prednisolone is one thing which you have to start right from the zero hour. You put every 1 hour, you put 4 to 6 times, depending upon the damage. Taper when there is epithelial healing is occurred, and then you continue 3 hourly or 4 hourly. And when you stop prednisolone, when the collagenolisis starts occurring, that's usually after 20 days, you can stop prednisolone and consider the other medications. You'll have to give topical citrate. Sodium citrate is a very good solution, which is available. RO makes it. I think many others also making it. You can put every 2 hours. That's very good because it reduces lysosomal enzymes. Topical vitamin C tablets, doxy, antibiotic eye drops are not necessary because acid alkali would have killed everything. But if you suspect infection in the follow-up, you can do that. Anti-glaucoma treatment is a must, and homotropin is a must. Painkillers are necessary because intense pain may be there. So this is the best membrane. This is what medroxyprogesterone is available in the market. After 20 days, when you stop steroids, you can continue medroxyprogesterone because this will not escalate the collagenolisis. Tear supplements are not necessary. When you're putting drops so many times, they are really not necessary. And that is the some of the things that I've already corrected. Topical steroids are necessary. And which are the best anti-glaucoma drops? The best anti-glaucoma drops are aqueous suppressants. In the later stages, after you have completed everything, there can be damage to the lids, which you have to look at, correcting the nasal damage. And these are overnight patching. All that can be done late. Autologous serum is very good when the epithelium is not healing. Umbilical cord serum can be utilized. Tarsorrhaphy can be utilized. Symblepharon release can be done. And industrial ophthalmology is very important. We'll have to educate. It's our duty to go to industries and tell them about taking precautions. It's extremely common. Burns are very common. They should have a shower available there to mitigate the body burns. And safety goggles is more of a fashion. They don't use it. Face guards like what we're using for corona against. So these are things which they're all available in the market. They'll have to use it. And amniotic membrane transplantation is a very, very big topic. It's extremely useful in all these burns. Whenever there is a non-healing surface defect, which is remaining for more than a few days, do not hesitate to take the patient for AMT. AMT and the limbal stem cell transplantation can be done either from the same eye or from the other eye, or it can be allograft also. And mucous membrane graft, these comes in very late stages. When the entire thing is damaged, then you'll have to look at this. Excimer laser also can be done if you are left with an epilar scar and which is not improving the vision after everything has healed. So the AMT is a totally big subject. You can it's extremely useful in alkali burns, and the limbal cell grafting is also there are many types of them. They are of extremely use. The limbal inlay graft is filling it up, and overlay is covering it up when there is a shallow wound. And sandwich is you can actually fill a defect there in a non-healing ulcer by the sandwich technique. So it can be used as a graft in conjunctival reconstruction. When there is a lack of large area of conjunctiva, then you can actually take an AIM graft and cover it up. And it can be for surface construction of the cornea as a graft on the surface. It can be patch in corneal surface reconstruction where you fill up certain things. And limbal stem cell deficiency, it can be used. And as a substrate for culturing, even when you want to culture limbal stem cells, laboratory will be using amniotic membrane. And epithelial and stromal defects. So epithelialization occurs over the amniotic membrane in such defects. And is a patch in the biological contact lens, and where it reduces the inflammation, it promotes epithelialization beneath the patch will fall off after some time, but it will promote the re-epithelialization beneath the amniotic membrane. So these are the conditions of the surface disorders. Pterygium, tumors, when you remove them, it's standard that we put in AMT now. No, it's standard to cover the area so that collagenolisis and scleral melting is avoided. That can be done with the conjunctival graft from elsewhere, or some people also use the AMT for that, but AMT recurrence rates are certainly higher. Whenever there's a conjunctival scarring and symplepharon, you can release them and put AMT there. Superior limbic keratoconjunctivitis is extremely useful. In addition to the glue, you can put you can add on the AMT. The conjunctivochalasis, where the conjunctiva is moving in the lower lid, under the upper lid or lower lid, it's very symptomatic. This is something which you'll have to look at by moving the conjunctiva. If it's really moving into lines, horizontal lines, this is something which can be fixed with either the glue or combined with AMT. Any ischemic conjunctiva can be supplemented by use of AMT. So AMT as a graft provides stroma as well as basal membrane on the normal corneal epithelium, on which the normal corneal epithelium grows. It grows on it, and it provides stroma because it has stroma. It has even in active corneal ulcers. Imagine there's a huge ulcer, it's not healing. You can, in addition to giving antibiotic therapy and all that, you can consider short of grafting. You can short of lamellar tectonic graft. You can consider, especially neurotrophic corneal ulcer, you can consider the amniotic membrane. When stromal lysis is absent, but there is a defect, it's not progressive, then you can consider the this thing. And here normal corneal epithelium grow overs on it because you have filled it up and epithelium grows on it. And absence of corneal vessels, reabsorption of due to phagocytosis and collagenolisis back to keratinocytes. And this occurs, the AMT that you have put in pits will get absorbed by collagenolisis, and avoid it in neovascularized cornea, because whenever there is highly inflamed cornea or highly vascularized cornea, then the AMT will not last, it will fall off. So you treat the basic condition, then you can come to the thing. So friends, I'd like to end here. The surface is a very vast substance. I have another slide presentation, which probably will keep it for next time. It's a very vast topic, extremely vast topic. You'll have to be a detective or somebody who looks into great details. The history is extremely important. History, all that you learned is very important here. You'll have to exercise in every patient. Observations without magnification, magnified observations, and some laboratory tests, some clinical tests that you can do, Shermer's and breakup time are very important, and understand the lesion and start treating it. Many times, disease that you see on the eye is because of over medications. Sometimes if there are dozens of drops they have, I'll ask them to stop all the medicines, wait for a day, nothing is going to happen, wait for 2 days, many times symptoms will come down. You'll have to divide the surface lesion into various aspects. It can be an allergic. You have to ask a question, is it an autoimmune disease? Is it due to trauma? It is due to infections. So if you classify them and then look at the components of the signs and symptoms and correlate them, and you will certainly be happy in diagnosing and managing this patient very well. Thank you.
Thank you so much, sir. I just one question, like for a non-cornea person, and suppose someone is not having, cannot refer such an emergency patient immediately. What are the measures they can take to prevent symblepharon if it happens either in a alkali burn or a SG syndrome?
The identification diagnosis is very important, sir. You have to unless you pull the lower lid and upper lid, you may miss the symblepharons. Many times it starts in the phonics. You identify them. The basic management in if you're talking about Stevens-Johnson's and some of these clarifying diseases, the basic the thing that you should do is manage the systemic disease extremely well, and then a lot of lubricants, a lot of topical immunosuppressants, steroids, whatever the disease process needs it, and with a glass rod, if they are trying to adhere, you can release them. That's especially in the active, very active diseases. You can even put a ring of silicone or a process if you have there and band-aid the eye. Bandaging is many times not possible because you'll have to, there is a surface defects and you'll have to keep putting the drops periodically. So that may not be possible, but a ring like that is of great use in such patients.
There are a few questions from the PGs. One is what is intense pulse light therapy?
Okay, these are therapies which are meant for MGD, and normally they are very expensive. And are they really needed in an average, moderate, or mild case? I'm not sure. We don't do that. But then basically they replace the warm fermentation. What is necessary is you have to remove the lipid secretions from Magoan glands that is done physically, mechanically, as I shown in one of the earlier slides. And what is most important is warm fermentation to be done first, and then express massage it. And warm fermentation massaging has to be done for full 10 minutes. The ideal temperature is around 50 degrees or 45 degrees. You can take hot higher temperature and reduce it as it cools, and basically give a lot of fermentation in that directions. And then you do the lid massage, lid cleaning with the either maybe shampoo or now some of the drugs are available with which eye drops are available. You can do it. The higher ones, pulse therapy, and there are things which massage. They're quite expensive, and we had that machine and we tried to do that, but then the cost is so high, but then the patient may not be agreeing upon it. Your regular warm fermentation done in the proper way. Show a video. Most of the time, you go to the OPD tomorrow and see, most of the time they are not doing it proper. Somebody is doing it here, somebody is doing it there. Doing in a proper way of the lid massage and lid scrubbing will mitigate the need for any other expensive gadgets.
Okay. Dr. Mamta, if you can unmute yourself and ask your question. I'm not very clear about the meaning of this.
Hello, sir. Yeah. I just wanted to ask if you're using amniotic membrane graft.
Yes.
In different cases, we should keep the stomach side of amniotic membrane up on the upper side. Like the stomach side should be kept up in whichever cases.
Yeah, see, it's either used as a filler or used on the surface. If you're using it as a surface, keep the epithelium surface at the top. If you're using it as a filler, you do it the other way around. So both sides will work. If you are not finding out, how do you find out? If you touch it, if the strands are not coming out, that is the epithelial surface. If strands are coming out, then you touch them with a swab stick, and that is the stromal surface. So you can use it either way, both sides it will work, but if you're doing it on the surface, I'd like to keep the epithelium on the surface.
Thank you, sir.
Am I clear? The voice is not very clear.
Mamta, you can mute yourself. There is some disturbance at your end. Mamta, can you mute yourself, please?
Is this audible now?
Yeah.
Yeah.
Yes, I got the answer that I was looking for.
Oh.
Thank you so much.
Thank you.
And there is another question. What is the difference between LipiView and mammography?
See, I have personally not used any of them. Mammography is identifying, if I'm right, identifying the meibomian glands. You can do it on your AR machine. You turn them upside down, and you'll see the meibomian glands. So that's watching the meibomian glands, whether they're intact, they're atrophied, they're spoiled, they're crooked, they're branched. All that you can find out. There are various machines. Our topography machine itself has got a camera which can take that photography. It can also measure the tear meniscus height. So these are all fancy gadgets. I think you should read about them only for the exams, but in practice, clinical examination will give abundant results. While the LipiFlow is identifying, quantifying the amount of lipid layer that you have on the surface of the tear film. So it throws a light, and then the reflection of the tear film, it can photograph and it can analyze the data. It's something like your breakup time. When the lipid layer is not there, holding the tear film will break there, and this is much more accurate than that to find out the pathology in the lipid layer and how are the meibomian glands are functioning, and whether the lipid layer is healthy or unhealthy. So in the first one, you're actually seeing the gland. In the second one, you're seeing the tear film reflection of the pattern on the top of the tear film. The topmost layer is lipid layer.
Okay. And can steroid be used for more than a week in chemical injury?
Excellent question. Steroids, I would like to use steroids till the beginning of till 20 days in a tapering dose. Initially, I may start every 2 hours, 3 hours, but I will not stop. But this patient has to be coming periodically for an examination. The moment lysis of the stroma starts, that's the time when collagenase is acting. That's the time when we would like to stop it and continue all the medicines, including the medroxyprogesterone. But it can be theoretically and in practice can be continued up to 20 days. Rishi, if you have any comments on that, you can tell.
Yeah, I just thought I'll add something. What I love is that once your surface is epithelialized, you can give steroids as long as you want. So the priority when you have an acute chemical injury or any acute burn of the ocular surface, even if it's an inflammatory burn, say from a Steven Johnson, is to epithelialize the surface. That is the only purpose of the primary management during the acute stage. So amniotic membrane is very useful, and like Sir said, putting these rings which have amniotic membrane in them. Nowadays you get these ready-made rings in which you can mount the amniotic membrane, insert them into the fornices. So they will help to heal the surface plus prevent formation of symblepharon. And if you have anything covering the open stroma, then you can give steroids, because steroids initially help to suppress the inflammation. But if you're giving steroids on an open stroma, sometimes it can trigger a melting of the cornea. But if your epithelium is covered, it's perfectly fine.
And second thing is, one question always comes whether to use prednisolone or dexamethasone because of the granules of the prednisolone. Is there any difference when in the choice of steroid when you use both these things?
Well, see, it's timing again. They proved that prednisolone is better. The granules are actually better because they go and get stuck there to the tissues, and it may be in one way better, but both of them will act. If it is both of them will act similarly, but if you want to use higher steroids, powerful steroids, you can use a high concentration of dexone, which is not necessary in this. So, the prednisolone is the one which is preferred by everybody because of better penetration.
And there is another question is between doxycycline and azithromycin, why is doxycycline
You
preferred?
can unmute yourself.
Sorry, I just had a point to add. If it's an alkali injury, you'd want a stronger steroid because alkalis penetrate in more. If it's an acid injury, it penetrates lesser into the anterior chamber, so you could manage with the dexamethasone.
But dexamethasone is considered to be stronger compared to prednisolone, no?
No.
No. Okay.
Now, on the ocular surface, penetration-wise, prednisolone is supposed to be better.
Better. And between doxy and azithromycin, why is doxy preferred?
Doxy has got multiple actions. It's not just an antibiotic. It also has got the effect on collagenase. It reduces it. It's a long story, but then it is supposed to be doxy or tetracycline. Both are equally effective. Tetracycline you have to take so many times. Doxy is longer acting. Remember, doxy has to be taken on empty stomach. If you taken soon after your food or soon after you've taken a cup of milk or something, it doesn't get absorbed. So give at least 2 hours gap, and next 2 hours don't take anything. That's what I usually say. But doxy is supposed to be better.
Okay. And sir, there is another question. What is LipiFlow?
LipiFlow, I just covered that. I didn't want to take the high-tech gadgets. LipiFlow is the same. It's question of looking at the meibomian secretions which are present on the tear film.
I think Rishi will cover it anyway.
Rishi.
So let's go to the next topic. And I take this opportunity to introduce Rishi. Rishi is my batchmate in fellowship. So there's not much to introduce. He's a very good friend. And when Dr. Satyajit asked me that for cornea, whom should we call for help? I told him Rishi as the first name. That's why he called you.
Thank you, love.
And
thank you.
He is the medical director at SWARUP Eye Center. He's trained in Shankar Netralaya, then LVPI, and has been a consultant in LVPI also before this. And he is the honorary secretary of Hyderabad Ophthalmological Society and editor publications of Telangana Ophthalmological Society. He has got the Achievement Award at AAO and many other awards. And today he would be speaking on dry eye. Rishi, please.
Thank you. At the outset, I'd like to thank Satyajit and, of course, Love for giving me this opportunity. And also Dr. Ravindra, it was lovely to hear your presentation, sir. I've been listening to you since my childhood, even when I was post-graduation, in my post-graduation. Sir has come to our city and spoken in our hospital meetings several times. So thank you, sir. So Dr. Ravindra has made my life a little easier. I don't have to cover into detail many things, and I will just try and cover the things which he has not touched upon. Are my slides visible? Full screen is visible?
Yeah. Yes.
Great. So I think among all the things that we see in our clinic, refractive error and dry eye are probably the most common things that we see. I think every second patient that you see in your clinic will have some element of dry eye. And even if you don't have dry eye, you will be giving him some treatment for dry eye like a lubricant as a placebo. So it's very important to understand this disease because this is something we are either diagnosing or managing day in, day out. And especially now with the lockdown happening, a lot of people are on their gadgets and dry eye has become even more omnipresent. So what is dry eye? So dry eye, there are lots of definitions we've read, but currently the world over accepted definition, dry eye definition. Earlier it was just called the DEWSII definition, but recently they have revised the definition and added a few elements. And so the current definition of dry eye is the DEWSII definition. DEWSII stands for Dry Eye Workshop. It is basically an international workshop in which they got experts from all over the world. From India, we had one person, Dr. Virendra Sangwan, who was at that time in LV Prasad. He was part of this committee, and from all countries, they had representatives, more from USA. And they all basically gave a consensus. All these experts contributed to different aspects of definition, diagnosis, management, and gave a systematic approach to dry eye. And most of us who talk about dry eye use this as a guideline for all the things related to this. So according to this definition, dry eye is a multifactorial disease of the ocular surface characterized by a loss of homeostasis of the tear film and accompanied by ocular symptoms in which tear film instability and hyperosmolality, ocular surface inflammation and damage, and neurosensory abnormalities play etiological roles. So there are many things in this. You have an ocular surface loss of homeostasis of the tear film. You have symptoms. You have tear film instability, hyperosmolarity of the tears, inflammation of the ocular surface along with damage, and neurosensory abnormalities. All of these elements are there in the definition of dry eye. It's not necessary all of them have to be there. Sometimes even one can be enough for you to make a diagnosis of dry eye. And dry eye is not a new disease. This has been there, defined in the Assyro-Babylonian scriptures as long as 3,500 years ago. And if a man's, and it was mentioned that if a man's eyes are affected with dryness, he shall rub an onion, drink, apply oil to his eyes. Many of these things we still do. Onion makes our eyes water, and we apply oil for MGD. So in addition, they also say, thou shalt disembowel a yellow frog, mix its gall and curd, and apply to his eyes. So they had treatments for dry eye back then itself. So it's obviously been a disease which has been there long before. Now, everything we tend to call as dry eye, any irritation, anything the patient has, we say dry eye. But it's important to be able to rule out the common things which can mimic dry eye or masquerade as dry eye before we leap to a diagnosis of dry eye. So one of the important things that one must look for in many of these patients is systemic diseases like rheumatoid arthritis or any other autoimmune diseases. And of course, these cases do have an authentic dry eye, which may be associated with systemic diseases. Then it's called as Sjogren's syndrome. You can have dry mouth, or you can just have a primary ocular disease, which we call the keratoconjunctivitis sicca. So this is the real dry eye. Lid margin disease is the other common condition which can cause dry eye because the tear film doesn't have lipid, or it has abnormal lipid, which affects the stability of the tear film. So it can be a very mild form, like is on the right picture, where you can just have blocked meibomian orifices with or without telangiectasia, or you can have frank anterior blepharitis with, matting of eyelashes, etc., like this, which could be even because of some sort of a parasitic infestation like Demodex. But there are many other conditions which are not really dry eye, but can present with a dry eye-like symptom or sign. One of them is the mucus fishing syndrome. I hope some of you know what this is. Since you are postgraduates, you should know this. There's a very nice little chapter or a page in Kansky about this. So mucus fishing syndrome is a condition in which people have a habit to keep putting their finger or a handkerchief or a corner of a paper inside the eye to keep fishing out mucus. They feel they have something in the eye which they need to keep removing, and because of that constant habit of removing things, they end up damaging their conjunctiva. You can see this in this. You can see fluorescent stain in the inferonasal area of the conjunctiva and abnormal SPKs in the corresponding part of the cornea. So because of the mechanical trauma, they damage the ocular surface, and that causes symptoms, and then becomes a vicious cycle. And because they have symptoms, they'll have more tendency to rub their eyes, and this goes on, and sometimes all you need to do is break the cycle by putting a patch on the eye or avoid telling the patient to avoid touching his eyes, and slowly the patient becomes normal. The other common condition which is often misdiagnosed is dry eye or allergic conjunctivitis is superior limbal keratoconjunctivitis. Often seen in patients with thyroid, but you can also see it without that. And the pathology here is that the superior limbal conjunctiva has become loose. And because it has become loose when the person blinks his eyes, there is a micro trauma to that superior bulbar conjunctiva, which causes inflammation. Inflammation causes the conjunctiva to become further boggy, and the cycle repeats itself. And the way to diagnose it, when you look at the eye and the person looks down, you'll see this corridor of congestion. If you put rose bengal, all of this will take stain, and this upper tarsal conjunctiva will also show inflammation. And I don't know if you can see my on the slide here, at the limbus you can see this little white line, and that is the line which is formed because the conjunctiva constantly rubbing at the upper limbus. And this is quite a diagnostic picture of superior limbic keratoconjunctivitis. You can of course have cicatrizing diseases of the eye like Stevens-Johnson, which of course do have dry eye, but the underlying pathology is something else. And even sometimes bad allergic conjunctivitis can have a cicatrizing kind of a presentation. So very often you will have keratinization at the lid margin, and even on the tarsal conjunctiva you can have fibrotic bands, which can help you diagnose what is going on here, which is beyond just dry eye. You may have symblephera or ankyloblephera also. Another very commonly underdiagnosed entity is the conjunctivochalasis. This is basically, again, just like superior limbic keratoconjunctivitis, which is at the superior part. Inferiorly, you will have these folds of conjunctiva, which basically prevent the tear from spreading properly on the ocular surface. So wherever you have these folds, the lid is not able to touch the limbus or the cornea properly, and the tear is not able to spread across the eye, and therefore it tends to drip out. And again, because of the blink related micro trauma, you will have inflammation of the conjunctiva and the cornea, and that results in symptoms and signs and continued inflammation. So again, it becomes a vicious cycle. The treatment here also, just like superior limbic keratoconjunctivitis, to remove this excessive conjunctiva either surgically or by means of cautery, and then they get a lot better. Another entity which you can actually have in dry eye is these lid parallel conjunctival folds. So because of inflammation, the conjunctiva does become a little boggy, and you can see these parallel folds which can be present in authentic dry eye. These are different from conjunctivochalasis, which you can see on the right side. So this entity has been described, and it has been given an abbreviation called LIPCOF, lid parallel conjunctival folds. If you look carefully, you will see these, and you can even see fluorescein staining in between these folds. And this has been defined in the DEWSII as well, and there's a grading for it. Grade 0 is no conjunctival folds, and grade 1 is 1 permanent and clear parallel fold, and 2 is permanent clear for more than 1 folds, and which are normally less than 0.2 millimeters in size, and grade 3 is more than 2 folds. And this is what it looks like. Usually if you put it on 25x your slit lamp, you can see like these little folds, but this is not conjunctivochalasis. Conjunctivochalasis is much larger in size, and it kind of overhangs over the lid. This is line. What is line? Can somebody unmute and tell me, one of the PGs, what is line? Line is a type of neuroepithelopathy which is seen after LASIK. We know that in LASIK you tend to cut the corneal nerves, and because of that you can get a mild neurotrophic keratopathy, which is called LASIK-induced neuroepithelopathy. Basically, this is the same as any neurotrophic keratitis. Wherever your corneal nerves are not going, you get a trophic effect. Just like in the skin, you get trophic ulcers. On the cornea, you get these SPKs, and this is what a neurotrophic keratopathy is. Basically, your tear homeostasis gets affected because your feedback mechanism is not working properly. And this also can mimic dry eye, but it's not really dry eye because you don't really have a absence of tears as such. Any component of tears not missing. It's the sensations which are not working properly. So yes, a neuropathic pain and neurosensory abnormalities have also been included in the definition, but it's not authentic dry eye as we know it. So that's the introduction of dry eye, and I'll just now go into the main thing, which is the diagnostic test. There were many questions related to this as well, and sir also has covered some of these, so I will try and skim through these a little fast. So it's a good idea to go in a systematic way whenever you're looking at dry eye, and the dry eye workshop has suggested a new stage algorithm for proper diagnosis of dry eye disease, from least to most invasive tests. So the first step is to do a questionnaire to assess the symptoms, like we do history. Then you go for functional tests to determine the functional, how it affects the functional visual acuity and also maybe even the aberrations of the eye. Test the tear film stability and then you want to look at the tear film volume, composition, and also damage to the ocular surface. So this is the staged algorithm. First, assess how severe is the eye discomfort. Does the patient have any associated dryness in the mouth? How long have the symptoms been there? Is the vision affected? How bad is the disease? Is there associated itching, swelling, crusting? Does the patient wear contact lenses? Any other general health problems that one should know about, including medications? This also includes looking at the anterior eye to look for any differential diagnosis that I referred to just now. After this, once you have suspecting a dry eye, you want to assess for risk factor analysis to look for risk factors like smoking, medications, contact lens wears, a lot of computer use, environmental factors, etc. Once you have established the dry eye, then you want to go into the diagnostic test. First, you want to look at the screening tests by means of dry eye questionnaires, which we have various types of questionnaires like the DQ5, OSDI, speed questionnaires. So any validated questionnaire can be used along with any of the homeostasis markers, which can be measured, and also the ocular staining. In clinic, really what we're looking at is the first and third, the breakup time and the ocular surface staining. We don't really have the tools to measure osmolarity, except some advanced expensive tools are available in the market, but most of us don't have access to these. So when in staining, you want to look for corneal as well as conjunctival staining, and I will be covering that in some time. Then you want to, once you have looked at all this, you want to basically try and classify your dry eye, whether it's more of an aqueous dry eye or more of an evaporative dry eye. Sometimes these are not very distinct, and it's more like a spectrum from aqueous to evaporative, and very often you have patients who have a little bit of both. And these again can be mild, moderate, or severe, both in evaporative as well as the aqueous deficient category. So when you're looking at the diagnosis of dry eye, you want to see if the symptoms are there, and if you have at least a positive result for at least one of the homeostatic markers like TBUT or ocular surface staining. This indicates a dry eye, and multiple tests, of course, will improve the sensitivity. You want to look for symptoms of any clinical signs, which can also be present, especially in the neuropathic pain. And these patients really, if you see the eye, it looks absolutely normal, but they'll say they have itching or they are very uncomfortable. We've seen many of these patients, even after cataract surgery, we have some of these. And often this could be a neuropathic thing in which the nerves are sensing discomfort, but you're not seeing anything. So in addition to managing the ocular surface, sometimes you also need to give other stuff for these patients. Sometimes you need to even do a psychiatric evaluation. Additional dry eye diagnostic metrics have to be done for subtype identification, and specific aspects such as inflammatory markers or environmental triggers may have to be looked into. The sequence of testing from least invasive to most invasive, and rule out other differential diagnoses like I mentioned earlier, including Demodex, which can be a common cause for blepharitis, allergic conjunctivitis, other causes of filamentary keratitis. Viral keratoconjunctivitis can sometimes present with symptoms, and one could often misdiagnose these, and other entities which were covered by Dr. Ravindra so beautifully. There are several questions that are available. One is a 5-item dry eye questionnaire called the DEQ5. Then you have the OSDI, and then you also have a speed questionnaire, a Sunday questionnaire. So I'm not going to go into these. You can use any validated questionnaire as long as you know how to interpret them. They also have a scoring system and interpretation system which you must understand. So a DEQ5 score of 6 or an OSDI score of 13 or more indicates a positive result. These are the most commonly used questionnaires. It's a good idea to have these. If you don't have them, they're available on the net. You can just take a copy. Many of these drug companies will also give you a free copy, a free pad which contains many of these. So you could use those. Why is it important to use a validated questionnaire? If I'm overshooting on time, please tell me and I'll start going faster. Unless asked, patients may not elicit symptoms. So sometimes it's important to ask leading questions. And it also helps you to understand the severity of symptoms and decide if there's need for additional testing. It's important to monitor progression and response to treatment. And symptoms should be measured similar to the signs. So you not just use the questionnaire right in the beginning. You could also use them later after you've done some sort of an intervention to see if it has helped. And also to get some sort of a standardization and quantification into your history. Otherwise, it's very subjective. Now coming to the important tests, the most common test, simplest test you can do in your clinic is the tear film breakup time. Anything less than 10 indicates that there's something wrong. Okay, and if it's lower, less than 5, it indicates there's definitely something wrong. Now I won't go into the details of breakup time. Basically, all of us know it, but important thing to remember is you want to see the random dry spot. So basically you put fluorescein in the tear and then ask the patient to keep the eye open without blinking, and you want to keep looking till a dry spot appears. Now if this doing this once is not enough, you should do it at least 2 or 3 times. And you must make sure that the dry spots are not always coming at the same spot. If the dry spot is coming at the same location, then it could be that there is some sort of an elevation in that area. There could be a pterygium adjoining that or a delin, and those don't count. You must look for a random dry spot. And the time from the moment the person stops blinking till this appears is the tear film breakup time. And usually it's 30 or 35 or more. But up to 10 is okay, but less than 10, there is definitely something going on. And it indicates that there is a problem in the stability of the tear film. Stability of tear film comes from the lipid and the mucin component of the tear film. So if one of these two are abnormal, tear film breakup time will be. The second important entity is the tear film osmolarity. The problem with measuring the osmolarity is in the lab it's easy to measure, but we have only one device which can measure in the clinic called the tear lab. This is very, very expensive, not just to buy, but also to do for every patient. You open a consumable, which is costly. So the cutoff value, they say, is more than 308 milliosmoles per liter. But it can be very variable depending on when you're doing this test. So they say that rather than going for one value, you look at the interocular difference. And if you have a difference of more than 8 milliosmoles per liter, then it may be more suggestive that there is a dry eye. And this difference increases more with the severity of the dry eye, because no two eyes are exactly the same. The third important thing we can do in the clinic is the staining, the vital staining. You can use lissamine green or sodium fluorescein or rose bengal. And basically, you're looking at staining of not just the cornea, but also the conjunctiva. So there are various stages available, Van Gisselbelt, etc. But simple thing is, if you have more than 5 corneal punctate spots or more than 9 conjunctival punctate spots, that would indicate that you have some element of dry eye disease, and then you need to evaluate more. So rather than going into the staging, you might need the staging for your exams. So I would suggest you look it up in your textbooks. But if you just see more than 5 corneal spots or more than 9 conjunctival spots, that would be significant to say that there's something going on. So based on these, if you have more of a tear film breakup problem, then it's evaporative dry eye, and then the pattern of staining will tell you what type of dry eye it is. So if you have a aqueous deficient dry eye like a keratoconjunctivitis sicca, the staining is more into the central part of the cornea and the conjunctiva. And if it's more of an evaporative, you'll see an inferior kind of a SPKs and rose Bengal staining which might come. So there are special tests which will help you to differentiate these two, like meniscometry or measuring the tear meniscus height, Schirmer's test or phenol red test. All these help to identify the aqueous component, and to check for the evaporative components, you can do a meibomian gland assessment like meibography, which is basically a infrared evaluation of the meibomian glands to see the structure and characteristics of them, the anatomy of them. You can do a clinical meibomian gland assessment on the slit lamp by trying to express the meibum and seeing the quality and quantity of the meibum. Interferometry is what is lippy flow. I'll cover that later. And an analysis of the blink. If your lids are not, you're having incomplete blinks or lesser blink rate than normal, that also can cause an evaporative dry eye. And any sort of a lid wiper epithelial can also be looked for by looking at the eye carefully on the slit lamp, and also the tarsal conjunctiva and the perilimbal bulbar conjunctiva. So meniscometry is again a simple thing. You can just see on the slit lamp and try to measure the or you can use expensive instruments. Nowadays you have lots of machines which can measure the tear meniscus more objectively. You can even use an OCT to measure it, and that has been described in literature quite well. But simply slit lamp, and you can use a graticule on your slit lamp to measure it. Schirmer's used diagnostic is significant, but a high Schirmer's need not necessarily rule out a dry eye. Okay, so if you have a Schirmer's less than, it is definitely abnormal, and if it's less than 5, it is diagnostic of dry eye. And essentially, a low Schirmer's tells you that the aqueous component is low. Essentially, it's a measure of the aqueous component. Evaporative dry eye, you can have very, very normal Schirmer's, and it wouldn't mean anything in an evaporative dry eye. It's more of a test for your aqueous deficiency. And you're using a calibrated paper strip of a certain Wattman filter paper, etc., of certain size, 5 into 35 millimeters, and the measurement is taken at the end of 5 minutes. You have various types of which is Schirmer's 1. Then you can do Schirmer's 1 with anesthesia, which eliminates the reflex tearing. And then you can have Schirmer's 2, in which you're doing along with nasal stimulation. The one which is practically useful is Schirmer's 1 with anesthesia, and that's the only one I perform in my clinic. So, because that eliminates reflex tearing. Otherwise, reflex can come if you have the fan going on, if you have bright light in the room. Use immediately anesthesia because you'll have to a while. Give some gap, and then with a kind of standardized lighting in the room, you can measure this with an. So Schirmer's 1 is the eye. It's important to look at the meibomian gland orifices on the slit lamp, and then also apply pressure. There are standardized instruments of certain fixed size that you can use if you want to quantify, or you can just use your thumb and apply pressure and see what kind of fluid is coming out. If it's transparent and just a little bit of fluid, it's normal. But if you have white cheesy material which is coming out, toothpaste-like material, that indicates that the meibomian glands are unhealthy, and the secretion produced by them is unhealthy and cloudy and opaque, indicates meibomian gland disease. The way to remember is normal meibomian secretion is like olive oil. It's transparent and thin.
I'll interrupt for
yes.
Rishi, your voice is breaking. So can you switch off your video and see if it is clear or not? Maybe due to the internet speed.
Okay, let me just see if I'm on the right Wi-Fi. Maybe that could be the reason. Is this better?
Yeah, this is better.
Okay, so I'll just use the microphone of my laptop. Okay. Do I need to repeat anything, or can I?
You can continue. You can continue.
Okay, thank you. All right. So after looking gland on the slit, Dr. M S Ravindra mentioned mebography is again a very useful tool, and basically you are quantitatively assessing the meibomian glands, not just the orifices, by looking at them with this special infrared light. This is present in many things, even cameras, night vision cameras have them. So if you have a security camera, even that can be used to look at this thing, but of course you won't have the magnification. Many of our instruments like the autoref, topography, OCT use infrared cameras, so you can use them to visualize. And of course you can buy a standalone thing. They're not very expensive. You can get something for as low as 3 lakhs if you want to buy a standalone machine, and they also have other things which you can assess with them. Of course, the more expensive ones can go up to 20 lakhs as well. So the advantage is that you can see not the glands which are blocked, but you can also see the glands which have been obliterated. For example, if you see this picture on top, you have some glands which are white, and then some glands you can see have got completely obliterated. So basically, when you have meibomian gland disease, initially the gland gets blocked, and because of the blockage, it becomes thickened and it becomes tortuous. But if your blockage is not open for a long time, eventually the gland and the acini will have atrophy, and then the gland will shrivel and it will disappear. So once that stage is reached, you basically have areas of dropout. And such a case, how much ever hot fermentation or massage you do, the oil is just not going to come back because the gland is dead. And then you have to change your strategy in these cases. Don't torture these patients with hot massage, hot fermentation massage. You need to give them the proper medication. But if you see more of blockage, then these are the ones who can really benefit from. So mebography, this is what the images look like. These are normal and glands which look like that. Those are my meibomian glands. So you can see I have fairly good glands, but there is some sort of blockage also because there's some sort of tortuosity. Now, this is also my LIPI view, which is basically an interferometry. So interferometry, it basically uses this. You can see this colorful pattern of the lipid on the tears. Even on slit lamp, you can see sometimes the colorful, like paint. If you put paint on water, you will see this color. This is what you're measuring, the thickness of the lipid film using this interferometry pattern, and it quantifies it. It gives you what is the thickness, and this machine is available from Johnson & Johnson now. This original company was TS Science, which has been acquired by Johnson & Johnson. And lipids moving, and this pattern is what is being assessed, interferometry pattern. This machine not just measures the interferometry pattern, it also measures, because it's doing a assessment of the dynamic assessment, it also gives you whether you're blinking, etc. So this is what the assessment report of LIPI view looks like. So it's giving you, on top you can see average LLT. LLT is lipid layer thickness, which is 53 nanometers in my right eye and 74 in my it also gives you the maximum and the minimum, and also tells you about partial blinking. You can see my blinking is which means that because of this I don't have dry eye. Okay, so this is previously we could not assess this because we didn't have these high-speed cameras looking at the eye, but blink dynamics is now a very important area to assess evaporative dry. The lipid layer, but also the closure of the lid if it's incomplete. Not just at night, that's nocturnal lack of thalamus, but even when we're working and doing normal activities, our blink, if it's incomplete, that also can cause evaporative dry eye. And advanced machines can give you blink dynamics. Now you want to look at the tarsal conjunctiva and the lid margin to look for lid.
Rishi, I think you. Hello.
These can be seen little dice like yes.
Rishi, the voice is breaking. Can you switch off your video once? Your own video?
1 second. So I should stop sharing and then again start sharing. I'll try that.
No, your camera you switch off. So at least your own
my camera video. Okay. Sorry, I didn't understand. Just a second. For some reason I'm not able to do it. Can you do it from your end, the host? Can you switch off my video and try?
No, sir. That rights are there with you. You can just click on that camera icon. You will switch off.
Unfortunately, my cursor has suddenly stopped working. I don't know why.
Because the internet bandwidth is low, sir. What I feel here is.
Okay, I'm sorry about that. Is it better now with going out of the presentation mode?
Yeah.
Now the voice is fine, sir. You can share the slides.
Yeah. My computer seems to have hanged.
That's possibly, sir, because
no issues. We'll also hang around.
I'll just stop here. Are there any questions for me at this point? I can just take them while I just get back on this.
Okay.
There is a question.
Yes.
Dr. Mamta has mentioned that tear film breakup time should be done before Sharma, and if we have used local anesthetic and stain for the tear film breakup time, then how do we do Sharma test?
So tear film breakup time should ideally be done before putting anesthetic, because anesthetic can also affect your tear film. So what you can do is you can just stain your fluorescein strip, wet it with a little bit of proparacaine, and just put a little bit in the fornix. But avoid putting anesthetic in the eye before you do the tear film breakup time. And then you can put anesthetic and do the Shermers after that.
Okay. And during Shermers, whether the eye should be open or closed?
During Shermers, your eye can be open. You don't have to close it or keep it wide open. You can even blink normally, like you would talking to somebody. So just ask the person to be normal, neither closed nor wide open. Can the admin or somebody close my presentation or stop my sharing, because it seems to have hanged? I don't know why. The host of this meeting, can they do that?
No, sir, because that rights are there with the individual. From here, I can't stop sharing. Just a minute, sir.
Press the power button for a while. Everything will go off, and then you can switch it on again.
But then I'll have to exit. That's the only problem.
We'll back ahead.
You can log in again, sir. That's not an issue.
Do the postgraduates have any more questions? Any questions? Am I audible?
Yeah,
yes, sir, you are audible.
Fine. If he comes back, I can tell about our experience with Demodex. He was mentioning about Demodex. Demodex is very common. Some of the studies have said in chronic non-responsive, MGDs, it can be as much as 70 to 80% of the time you may have Demodex. Demodex is a tiny organism which lives in a follicle. You have a follicle through which hair is coming out. I don't have the video right now. And inside the follicle, lot of them were like 4, 5, 6, 10, 20 can be there. So they are the ones which secrete toxic fluids. And then how do you diagnose? Basically, the non-responsive to response comes back again. Then look at the roots of hair lashes. There will be a cuff around it or some dirt sitting on it. Any amount of scrubbing will not go away. You clean it up, then again it comes back because there are thousands of them are living there. So we did one study wherein we plucked out 4 hair lashes from the upper lid and 4 hair lashes from the lower lid. And then we did something called glycerin mounting. That's what they say, and see it in a microscope. You can see the live organisms jumping around. It's nice to take a videograph also. So it's a very common disease, and the treatment for that is massaging that with tea tree oil. Tea tree oil. It's not from tree, it's a small bush, and oil comes from there. It's usually available in organic shops, the cosmetic shops. They are available in small bottles, quite expensive, and you have to dilute it to 5 to 10%. I mean, if it is 100% oil, then you add 1 ml to 9 ml, so it becomes 10% or even 5%. It should not be more than 50%. It should be less than 50, but ideally 5 to 10. And then you can mix it with coconut oil, pure coconut, not the commercially available, edible coconut oil or linseed oil. Then you can apply it on the lashes. You have to start doing it for about 2 weeks time. And this has to continue, twice a day. And this has to continue for about 4 to 6 weeks time. We detected a lot of cases of Demodex in chronic blepharitis, chronic MGD cases. And I had one video also on that, but couldn't present it. But then always suspect it. You talk to your laboratory person in your microbiology and just pull out 4 lashes which has got the cuff, and you can see these organisms there. We also have tried systemic anti-arthritis. They work there, but the best is massaging with physical massage, expression, plus application of tea tree oil onto that. Like kajal, you can apply it on kajal. It works very well.
Before he's coming, sir, I'll ask you a very simple question which everyone faces while treating dry eye. How do you decide which molecule to give while treating? So many are available.
I think the friendly representative will tell you which one to use. I look at, see, it's a HPMC is, you have to classify them depending upon the disease processes. It's a big lecture. HPMC is one of the standard one. And I also look at the price factor. So we have a chart here. HPMC, there are 10 companies. Each company has got a different price. So we are very sensitive about it because it can cost anywhere from few rupees to few hundred rupees. So we'll have to look at the patient's affordability. If you do that, it will be better. You can have one drug on HPMC side, which you can give it for certain group of patients. The other one is hyaluronic acid based ones. The other one is everything has to be preservative free. There's no need to take the one which has got arch on the surface epithelium. And there are additives. There are now various kinds of substrates that are added to that. And then you have hypotonic group. So you classify them and keep it in your desktop. HPMC is the cheapest one, hyaluronic acid when it's really necessary. And there is nothing that for a lipid abnormal tears, there is nothing available right now. It should ideally come with a certain amount of oil. Somehow nobody is manufacturing anything that has got oil in it. So in such situations, I ask them to use around the eye, not to go inside some coconut oil or castor oil at night time, which is clean, edible oil. So that is to be basically avoided because it all will have fungi because they are coming from plant source. They will be rich in fungi, so you should see that it doesn't go inside the eye. A lot of people put castor oil into the eye in the villages, and they would have done it for a lifetime, but they are lucky, that's all. But oil should not be directly used in the eye. So if you classify them into hypotonic tears for hyperosmolar statuses where the evaporation is too much, the tear will, because water goes away, it becomes hyperosmolar. In such situations, go in for hypoosmolar tears. And HPMC, if you are not diagnosed, I would rather go to HPMC in such situations.
Okay. And
I mean,
what
keep in mind
about
the price factor. This is what I would like to convey.
that is again for me also, most of the time I'm not able to prescribe Sustain Ultra for the cost only.
It's because it's become more of a placebo. Like
Yeah.
anything, you're not diagnosed, you're not specific about anything, you prescribe tears. Patient has nothing, you would just want the patient to get away from your this thing, you prescribe tears. He'll honestly use it for a month's time and come back. The diagnosis of I think he's going to tell you how to diagnose, classify them into 3 or 4 categories. Then you can specifically give that particular medicine to the patient. That will be a little more scientific. Never use tears if it's not actually needed.
And what about use of cyclosporin for dry eye?
It's a very good tool. Cyclosporin and tacrolimus both are excellent. They are available now. Tacrolimus specific to the eye is available. My first priority is tacrolimus, and I use it in allergic conditions like vernal catarrh. Of course, in where there is inflammation, chronic inflammation in the eye because of as an immune suppression, you can use it, and they are available. Cyclosporin is extremely of great use, but extremely expensive. They are pretty expensive.
And percentage of cyclosporin?
See, it depends upon what you're looking at. If you want the immunological action on it, you'll have to go for the higher percentage. I'm not sure which one is that. Then if you are looking at the dry eye components or the the basic inflammatory component to get lost, you can go in for the 0.05. I'm not really sure about the percentages, but we use more of tacrolimus in our situation than the thing. Tacrolimus, I will specifically ask them not to put inside the conjunctiva. What I ask them is, I teach them wash your hands, dry it up, take a small amount of tacrolimus on a finger, pull the lower lid and apply it like kajal. That way they are very comfortable. They can use, even children can use it.
Hello. Yeah, I'm able.
Yes.
I'm sorry about the confusion, but I think I'm back now.
Yes.
Yeah. Yes,
Right.
Continue.
I'm just. So if there are any time, we can just continue those.
Yeah, you can continue with your presentation.
Yeah, I'm just waiting for slides to open. 2 minutes. Sorry about the technical glitch.
We are not familiar with this Microsoft Zoom.
Yeah, Zoom. We are all.
We should get familiar.
By the time, sir, there is another question. What about tear meniscus height measurement? That Rishi has already covered, I think.
So is my audio okay now?
Yeah.
Just going to share my slide.
No slide.
Okay, is that okay? Can you see the slide?
No.
Yes, now we can see.
Yes.
Okay, great. So I think I'll avoid going into slideshow mode because I don't know if that's what's causing the problem.
Sir, we lost your audio, sir.
Hello?
Yeah,
Am I audible now?
Yes.
Can you see my slides?
No, sir, it's not coming. I think you're sharing the screen.
Okay, let's
let me, the diagnostic part is predominantly, I don't really need slides to explain, we just speak. Is that okay? I can look at my
that'll be
slides
good.
and
That'll be
talk.
Good. Good.
Is that okay?
You can stop sharing the slide only and just give your talk.
Yeah, I think we'll just do that. So that, yeah, just but I'm going to look at my slide. So I was essentially at my last slide to look at the lid viper epitheliopathy, in which you get staining at the lid margin, which indicates that your lid, when it's coming in contact with the ocular surface, there is some sort of friction, and that can be found by staining the lid margin also and seeing if there is any lissamine green or rose bengal staining there. Like I mentioned, but it's not very accurate, and it's sometimes gives a lot of fluctuations. So rather than actually measuring the tear film osmolarity per se, you can measure the difference between the two eyes, and that is supposed to be more suggestive of dry eye. But again, okay, and that is supposed to be. Is it now? Am I audible?
No, Rishi, it's absolutely distorted. It's not clear.
And now
if
can
Rishi
you hear
switches
me?
off his video, now it's clear.
Okay. So next, coming into the main part, which is therapy of therapy is lubricant, but there's a lot more in the management of dry eye, which one must understand. So the strategies is, of course, you have to fix the tears, but just supplementing the tears by means of lubricants is not enough. So tear supplementation is one way, but you also want to try and retain whatever tears the person has, and that is called tear retention, which could be by means of moist chamber glasses or punctal occlusion. Tear stimulation by using secretagogues like pilocarpine. Mucin secretagogues are now available also, like ribapamide. You can tear substitution either by means of salivary gland autotransplantation or by means of autologous serum drops. And finally, you want some anti-inflammatory therapy, because there is an inflammatory component also to dry eye, for which we can use topical agents like cyclosporin and even mild steroids. Environmental strategies also play a very important role, especially in evaporative dry eye. Highlight the stepwise management of dry eye, diagnosis and subclassified dry eye. You want to depending on this. First, you do step 1. If that doesn't work, then you go to step 2. Then if that works, you go to step 3, 4. So there are mainly 4 steps in the staged management algorithm of dry eye. The step 1 is education of the patient regarding the condition, its management and treatment. Modification of local environment. So if the patient is in a very air-conditioned of an environment, you want to shift him to a cooler, which is got moisture. If the patient uses a very high-speed fan, you want to make them shift to lower speed or stay away from the fan altogether. Dietary modifications, you want to give them diet which is higher in essential fatty acids and omega. You want to remove any offending agents, either topically or systemic medication, which can cause dry eye. And if you're giving, you want to also supplement lid hygiene and warm compresses. That also comes into the stage management. And of course, lubricants. Depending on the kind of dry eye, if you have MGD, you want to give them lipid-containing lubricants. If it is just a aqueous deficiency, you can give any lubricant, even with a mild preservative. If the step 1 is not working, then go to the step 2. Any problem? Is my audio audible?
Yes, audio is absolutely all right.
Okay. Then I think somebody else's audio is on and there's some disturbance because of that. Yeah. So if the step 1 is not working, in step 1, the lubricants can have preservatives. But if the step 1 is having a problem, then you shift to preservative-free lubricants. Because in dry eye, you need to dose frequently. So up to 4 times, if you're dosing, a preserved lubricant is fine. Even BKC is okay in mild dry eyes. If you have a or
I can't hear you.
it was because a little more disappearing preservatives. You want to avoid determined preservatives. So, to maybe punctal occlusion and then in-office treatment flow, etc. Be part of this step 2 of the staged algorithm. Topical cyclosporin and oral tetracyclines, as were mentioned by Dr. M. All of these come to the step algorithm. If the step 2 is not working, then you go into the step 3, which is oral secretagogues like oral pilocarpine, allogenic serum drops like autologous serum, therapeutic contact lenses, and even rigid scleral lenses can be used. The final step is the step 4, in which you have to think of a stronger anti-inflammatories like topical steroids, and you can think of a surgical punctal occlusion, amniotic membrane graft, other surgical approaches like tarsorrhaphy, salivary gland transplantation. This is essentially reserved for very, very severe cases which are not responding to your normal medications and the previous steps. Now, when you talk about lubricants, it's very confusing. You have different molecules, different preservatives, different additives. So how do you select a lubricant? And that can be very, very confusing. The medical reps will come and tell you, this is the best lubricant, this is the newest one. So remember that when you're choosing a lubricant, there are many things that you want to look at. A lubricant is essentially a hypotonic or an isotonic buffer solution containing electrolytes, surfactants, and various types of viscosity agents. The active molecule, which we say CMC or HPMC or PEG, that is a viscosity agent. But other than that, you also have electrolytes, surfactants, preservatives, which help you select which one lubricant over the other. So preservatives, when you talk about, you have 3 main types. The toxic one is benzalkonium chloride, which is highly avoidable. And nowadays you have many lubricants which don't have this. You have less toxic, which is polyquad or purite, which is sodium chloride, and sodium perborate. These are the 3 which can be less toxic, and they are almost as good as preservative free. And of course, ideal one is preservative free. But the problem with preservative free is there's a possibility of contamination. The reason you put preservative is prolong shelf life and prevent secondary contamination. So if you don't have preservatives, they can get contaminated. So either you should use single-use vials, which are called unims, or you can use specialized type of multi-dose vials. Nowadays, you have these called the Novelia bottles, which have a valve in them, so they prevent air from outside entering them. And that may be one way you can use a multi-dose preservative-free lubricant. The viscosity agents, low-odes are available. HPMC was the one we used to use earlier, which was Tears Plus, or now you have CMC, polyvinyl alcohol, methyl polyethylene hypromellose, glycol 400, polyethylene glycol, hydroxypropyl cellulose, and sodium hyaluronate is the newest kid in the block. Everybody's talking about it. But really, if you ask me, this viscosity agent is the least important thing when I choose a lubricant. More important than that are the other characteristics of the lubricant, like what is the dwell time, how long will this lubricant stay in the eye, how long will the protection last, how much blurring will it cause in the vision, how much caking of the lids, which is crusting of the eyelashes, how comfortable is it, does it sting on putting, does it have preservatives or does it have bad preservatives, So these are the things which will help me select. And of course, what are the additives? Does it have oil? Does it have electrolytes which help to reduce the tonicity of the tear film or make it hypotonic? So all those things will help me select. Or is it hypoosmolar? Does it substitute the mucin or lipid component of the tear film, which would be useful for dry eye? These are the things which help you more than the viscosity agent per se. Now, when we talk about lubricants, other than drops, you also have ointments and gels which are available. The advantage of these is they have a longer contact time. I know I'm running over. I'll try and finish quick. The second advantage is that they coat the surface. So especially at night time, they give you a prolonged protection, especially if the patient is having a little normal lag of ophthalmos or something. It can help you to prevent evaporation of the tear film and drying of the eye in such cases. These basically have a formulation of special mixture of either a mineral oil or petrolatum or some sort of an oil base or a petroleum base, which helps it to become longer lasting and coats the surface. The advantage of ointments is they do not support bacterial growth so often. They don't need preservatives at all. And that's one. And that's why it may be less toxic actually. Gels containing high molecular weight cross-linked polymers of acrylic acid, such as carbomers, have long retention times than tear solutions. But the disadvantage is that they can cause blurring, more blurring than petrolatum ointments also. So you can't use them during the day too often, and sometimes you have to reserve these for the night time. So that's about lubricants, but medication of dry eye involves many things beyond lubricants. Anti-inflammatory therapy has a role, like I said, topical cyclosporin and even mild steroids, autologous serum in more advanced cases, and of course the procedures like punctal occlusion, procedures to increase the lipid output from the glands like hot fomentation or lipiflow, etc. Intense pulse light treatment was talked about as well. So what is IPL? IPL is basically a very bright light of 500 nanometers, which is given as pulses. And dermatologists have been using this for treatment of acne on the face for a very long time. And now we are using it for meibomian glands, which are essentially very similar to our oil glands on the face. And basically what happens with this bright light is it causes blood because the vasculature around these inflamed glands is reduced, the blood which brings these inflammatory mediators is reduced, and that's why these glands become more normal, and then they start secreting more of a normal secretion. And that's essentially the same way in which it would probably work through the meibomian glands. Now we're not directly exposing the meibomian gland, we are putting the light on the skin, and through the skin you are essentially affecting the blood RBCs in blood vessels. And it seems to be working, and there have been some studies which have showed some encouraging results as well. The disadvantage is the effect is short-lived, so you need to keep repeating it. And most of the studies have shown this with a combination of meibomian gland expression. So we really don't know whether this alone is working or it's a meibomian gland expression which is working. But as long as something is working, because these are sometimes disparate eyes. The LipiFlow is essentially a very expensive way to do hot fomentation and lid massage. It gives you a high temperature and compresses the lid with some specialized type of a vacuum kind of a mechanism. And it's an expensive machine, like Dr. Ravindra mentioned. Not just the machine is a special device for every treatment, which is quite expensive. So most of our patients will not be able to afford it. If you can do in massage, that is probably better. So call the patient, and then you do manually massage with heat. You have special types of forceps in which you can actually squeeze out the meibomian glands, like they used to have these forceps for trachoma to squeeze the lids. In addition to that, like I said, anti-inflammatory treatment has a very important role because it breaks the inflammatory cascade of eyelid inflammation, tear film instability, hyperosmolality, and ocular surface inflammation. This cascade has to be broken, and that can be broken by using a topical anti-inflammatory like cyclosporin. 0.05% has been shown many studies that it works. And how does it work? It reduces the lymphocyte infiltration and thereby reduces the apoptosis of lymphocytes in lacrimal glands and conjunctiva, suppresses apoptosis of lacrimal gland, and reduces the interleukin 6. So basically the inflammatory cascade is broken and thereby you're able to suppress the inflammation in the eye. Finally, coming to surgical options, milder surgeries are to reduce the egress of tears from the conjunctival cul-de-sac, so you can cauterize the punctum or suture it up or put an membrane on it. Punctal cautery is really the simple way, but sometimes the effect goes away in a few months. We need to repeat it, but it's very easy to repeat. So in my clinic, that's essentially what I do most of the time. I don't even use plugs because this is more effective. You can use plugs are of different types. Initially, you can use temporary plugs to see if it's helping, and if the patient is benefiting from them, then it would be a good idea to use permanent plugs. Again, you have punctal plugs and you have canalicular plugs. Both work. Punctal is sometimes irritating because they jut out. Canalicular plugs called the Herix plugs. They are very soft silicone plugs and they work beautifully. But the disadvantage of these is sometimes they can go through into canal lacrimal system and even go into the nose, and you may not even realize it. So sometimes you have to transilluminate through the lid to check if it's there, and if you have a doubt, sometimes you have to repeat this procedure in these particular patients. The temporary plugs are of two types. You have short-term plugs which last only few days. This is just to see if putting a long-term plug is going to help. And then you have long-term absorbable plugs which can last up to 3 months also. These may be useful when you're doing, say, a dry eye patient with, you're doing a LASIK or a cataract surgery in one of these patients. So you want a period where you have a lot of tears in their eyes. Or if you have a very bad case, you want just for some time occlusion, but you don't want a permanent occlusion because then the patient might go into watering. You could try this till the patient's vicious cycle of inflammation and dryness is broken. And then once the tear film stabilizes, the effect would go away. Permanent plugs, of course, I already talked about. They can be made of acrylic or they can be made of silicone, and they work just like punctal cautery. So to conclude, of course, in very advanced cases, you have to do transplantation of the parotid duct can be put into the eye, or minus salivary gland transplantation from the lip mucosa, etc. These are reserved for more severe cases, and very bad cicatrizing dry eyes. You may even need a keratoprosthesis, like an odontokeratoprosthesis. That's beyond the scope of this particular talk. So to conclude, it's very important to diagnose dry eye systematically using history, questionnaires, clinical evaluation, diagnostic tests. Management strategies will depend on the cause and type. Medical management with tear supplementation and anti-inflammatory therapy is the mainstay of treatment of dry eye. But in more advanced cases, sometimes you have to resort to surgical measures to increase tear retention or tear production. Thank you, and sorry for all the technical glitches. I'll just end with one statement. A tear is made up of 1% water and 99% feelings. That's why a neuropathic pain is a definite entity. Thank you.
Thank you.
Thank you, Rishi.
I'm
Dr.
sorry,
Satyajit had one question.
internet was bad and you couldn't really see some of the slides, but I think management we could manage without video.
True.
So I'll be happy to take any questions unless it's too late. I know you guys must be all getting late for dinner.
Man.
Where do you
Love, go ahead.
and forceps?
I'm sorry?
Meibomian gland forceps.
Yes.
Forceps that is used to press.
Yes.
Which company provides that?
All companies have them. I use from Esico. It's a bit expensive, but any blunt instrument which doesn't have teeth, you just press the lids. And you can even roll times. Dr. Ravindra would be able to tell better. You can roll the gland from top to bottom, the whole tarsal plate vertically.
That's all the questions. No more new questions are there.
Great.
It was already covered in between the talk only. But
Thank you.
thank you so much. Thank you, Dr. Rishi, for
Yeah,
taking out
thanks
the time.
for internet issues.
No, that is not. But that is not the thing. But you still covered it without the slides also. So, but thank you so much. Thank you for taking out the time and the effort. Thank you, Dr. Love, for moderating it so well. Thank you, Dr. M S Ravindra. Sir is there. I think he has left.
Here throughout, I was listening to Rishi. It's always enriching. Learned a lot. Thank you so much for arranging this and to help postgraduates. Even
Thank you. Yes, a very good effort, I must say, CHATTERJEE. Congratulations.
Thank you so much. Thank you so much.
Thanks, Dr.
Thank you so much, sir, for all the effort, time, and your blessings, sir.
Star-studded fact. Thank you.
Thank
Hi,
you. Thank you,
Rishi.
love.
Say
Bye.
hello
Bye.
to everyone.
Thank you, Rishi.
Nice seeing you.
And a big thank you to Intas Pharmaceutical once again, Manish ji, who bring this all together every evening for the last 2-3 months. Thank you, Manish ji, and thank you, Chandrasekhar ji. Big thanks to Intas for doing this all for us. Thank you so much.
Thank you.
Thank you, sir. Thank you. Thanks over to all the speakers. Thank you, sir.
Thank you.